Thank you for allowing me to present today on the real-world effectiveness of stop smoking care in Ireland. Um, so why is this important? Well, we know the prevalence of smoking appears at this stage to have plateaued at about 18%, which is a long way short of the Tobacco-Free Ireland goal of less than 5%. In addition, smoking remains a leading preventable cause of health inequalities in Ireland, and there are concerns that untargeted stop smoking services have likely to have widened health inequalities. So Quit Manager was a new health information system introduced a couple of years ago to record data on HSE-assisted quit attempts. The data collected in Quit Manager was then able to facilitate assessment of real-world effectiveness of the stop smoking services provided by the HSE. So this study looked at Quit Manager data in order to assess both data quality and to look at the factors associated with service effectiveness. So this is a bit busy, but I'll take you through step by step. So at the time of writing, since the 1st of January 2019, almost 20,000 records were opened in Quit Manager. From a data quality point of view, we looked at 14,800 of them, and we did identify issues in a number of quality variables such as completeness and validity. Those 14,800 records pertain to 11,607 individual clients who had made quit attempts, because a client can obviously have more than one quit attempt. So of those 11,600 clients, we did the descriptive analysis at that point, and we found that although smoking is more common in males, with about 55% of smokers being male, and that 60% of our clients in the quit services were female. And unfortunately, we didn't have any good markers of socioeconomic status, so we kind of took education and medical card entitlement as proxies for socioeconomic status. And it looked like, based on these findings, with 60% having a medical card and only a third having third level education, that perhaps people from less affluent backgrounds were at least accessing the stop smoking services. The first step in the standard treatment program is to set a quit date, and of those 11,600 clients, almost 6,000 or 50% set a quit date. And as per the Russell standard criteria, this is the first step in being called a treated smoker. We then use that number for our intention to treat analysis, and found that, just in the interest of time, and found that almost 50% were still stopped smoking at 4 weeks. And again, here we found that older age and having no medical card entitlement was associated with service effectiveness at 4 weeks. And then at 52 weeks, we found that 18.5% of our treated smokers were still stopped at 52 weeks. And again, male, older age, and no medical card entitlement were all associated with service effectiveness at 52 weeks. So what can we say from this? Well, there's clearly room for improvement in data quality, and improving data quality management will increase the utility of Quit Manager. The areas for quality improvement that we have identified at this stage is a need for increasing pharmacotherapy use, being able to identify clients who may be at more risk of unsuccessful quit attempts in order to be able to provide additional supports to improve service effectiveness. And this might include things like expansion of the current peer-led programs such as We Can Quit, or targeted use of financial incentives. Here are some of my references, and I'd just like to thank particularly Aisling Sheridan and Paul Kavanagh and their colleagues from the Tobacco Free Ireland.